Good afternoon, everyone, and welcome to a special bonus extra BrainMap session, the seminar series brought to you by the P41 Center for Mesoscale Mapping that's here at the Martinos Center. Thank them for the pizza. Thank you for your attention. Thank you for recording so you can watch this from wherever. My name is Randy Kirschtick. I am one of the faculty members here and have had the pleasure of meeting our speaker a couple of years ago when we were in Glasgow. And she was presenting because she had just won the Young Investigator Award. So it was so cool to meet her and get to know her work. She is impressive in so many ways, which you're going to see when she shares her talk with you today. But amongst those is that she talks and studies about things that I think are super important, which is the relationship between your brain and how it functions or dysfunctions and the rest of your body's health. So your brain is really the squishy organ in your body, and it only works as well as the food that you're eating and putting into it, and the air that you breathe, and the exercise that you give it, and all of those things. And the health really matters. And so Ye, who's a trained physician in China, who's also a very expert neuroscientist who's worked with large-scale data, neuroimaging, and other kinds of data, particular deep expertise with the UK Biobank, as you're going to see today, has really learned very interesting approaches to how to address those tricky questions and to pick them apart. And yes, she can tell you herself her pedigree because she's exquisitely well trained, but I just want you to know how much I respect and admire her work and how glad I am that she's here to speak with us today.
Thank you so much, Randy. That's such a generous introduction. I feel so flattered. Yeah, thanks everyone for coming here too. I know here is a very imaging heavy, probably people hear a lot of expertise in imaging analysis for me. So my background is also in, as Randy mentioned, I'm a psychiatrist and neuroscientist by training. So I did my PhD about in Melbourne as well. And so I finished my PhD in 2020, and now I'm starting my new research group, looking at brain-body interactions and how that might be relevant to understand the physical mental comorbidity that I've been thinking about over the past few years. So without further ado, so my background, my research primarily sits between psychiatry and neuroimaging. So one arm of my research, I'm interested in using neuroimaging to understand brain function and organization, and also to understand brain circuits that might be relevant to neuropsychiatric conditions. But for this is an example of my earlier work where I use functional MRI. I derive a brain subcortex atlas based on resting state functional connectivity. So what you can see here on the left is the way, so every puzzle in this atlas is defined by distinct whole brain connectivity pattern. So we made this as a high hierarchical level with 4 different resolutions. So the one shown on the left is the most coarse level that recaptured the neuroanatomy, where the one on the right is the finest level with very fine detailed connectivity pattern. So this atlas is available to download on GitHub, and anything if you want to use this atlas, if you run into any trouble with this, I'm also always happy to help. And over the past few years, I've been keep thinking about not just studying the brain, but because we know the brain is constantly interacting with the rest of the body. Even from this very textbook style diagram, we see that the brain is interconnected with the rest of the body with different organ system by nerves. Similarly, the brain is also connected with other organs by arteries and veins. While despite this the brain-blood barrier, they still constantly changing information among them. And another motivation that drive me go into this field of brain-body interaction is actually very practical. This is the very prevalent physical comorbidity in psychiatry that I have seen back in my medical training. And also you can see from the slides, recent study or in the past decades, a lot of studies have tried to understand the physical health issues in psychiatry. And there has been a lot of acknowledgement of the previous underestimates and poorly attended physical health issue in psychiatry being highlighted in those either reviews or perspectives or epidemiological studies. And overall, we can see that, at least from previous evidence, people with mental disorders, they have 2 to 3-fold increased risk of developing chronic physical conditions like heart disease, diabetes, stroke, etc. And people also often have reduced life expectancy of 10 to 25 years. And importantly, the majority of years of life lost in those people relates to poor physical health. If we're talking to a public person, they might think because of suicide associated with mental disorder. But actually, if we look at the data, if you look at the patients, and this the poor physical health that can explain the majority of the years of life lost. So this further emphasizes the importance of looking or put more attention to this physical health issue in psychiatry. Indeed, if we look at all the epidemiological evidence, people have shown evidence that mental disorders is associated with an increased risk of a range of different chronic illness conditions, and that leads to significant increased morbidity, disability, and mortality, which also leads to substantially increased global health and economic burden. However, despite all the epidemiological evidence, from a neuroscience or biology background, we still don't really know what's the biological explanation of those epidemiological links. And especially when we only look at epidemiological evidence, they heavily rely on medical records of diagnosis. However, we know there is existing health disparities for people with mental disorders. They have lack of access to adequate primary care. There's also this historical issue of diagnostic overshadowing, and also they have their own difficulties of acknowledging and reporting medical problems to professionals. So this suggests that we might need to have alternative approach to characterize the extent of physical health issue. If we only look at medical diagnosis, the issue may have been underestimated. So in this study, what's the way forward? So in my opinion, we need to understand the phenomenon, the epidemiology, and also the biology, and also we need to understand the mechanisms. Here are listed a few potential mechanisms that have been proposed in the literature, including but not limited to those aging, inflammation, metabolic dysfunction, etc. Once we have a good understanding of both sides, phenomenon and the mechanism, we can then hopefully develop evidence-based interventions to really address this issue. So emphasize physiology and also the few mechanisms I might talk about today. So in terms of physiology, to understand that in this study, instead of looking at medical records only, I utilized the large-scale imaging biobank, and also they have the very large number of sample size, and also with imaging, and also with blood biomarkers and physiological markers. To be noted that most of the studies, neuroimaging study looking at psychiatry disorders, they only have the brain. And only recently, the UK Biobank, they released a lot of blood biomarkers, physiological measurements. So that actually enabled, only without that, we cannot do this study. So in this study, we focus on a few common psychiatric conditions, including schizophrenia, bipolar disorder, depression, generalized anxiety disorder, and as a comparison, we'll also look at dementia because we know it's neurodegeneration, it's a neurodegeneration condition. And in the study, we included over 100,000 participants, adults across whole adult lifespan from 18 to 90. So we analyzed a wide range of phenotypes, including those derived from brain imaging, as well as those from the blood, physiological measures, and heart rate, and also pulmonary assessment, like the spirometry test that people are very familiar with. So the idea is, so we want to understand the disease-related division in those phenotypes, but we know that a lot of phenotype that vary. I think someone is at the door. They want to come in, maybe. Oh, sorry for interrupting. I just saw that person and just, yeah, I'm not sure. Okay, sorry. Because a lot of phenotypes, they vary as a function of age, and also we know they differ between male and female domestically. So in this case, to really understand the individual variation that might relate to disease, so we used the idea of normative modeling to actually set a benchmark first against its age and sex. So for people who are not familiar with this idea of normative modeling, I just give a very quick example. So it's like the idea of brain charts or pediatric growth charts. So we can know for at a certain age, if you're male, female, what's your expected marker, or expect height, or the brain thickness, what you are expecting. And we can see whether an individual is deviated from that normative range. So in this case, so now we have trained this model using a wide range of healthy participants, age all adults from 18 to 90. So the model has been fitted. So the solid line in the middle represent population median, while the dashed line from the bottom to top corresponding to 5, 25, 75, and 95 percentile. So this shows us the distribution across population and what's the expected population norm. So once we have the model ready, then we come, so this phenotype is mean cortical thickness, just as an example. So we come another individual not included in the model training. So we measure this person's cortical thickness, and we look at what's their cortical thickness compared to the model. And this is that the first individual is a 30-year-old woman. So her cortical thickness is the same as what we show in the population in the median. So this person is not deviated from the population norm, and the deviation score, which is z-score, is 0. Here comes to a second individual. This person is a 50-year-old woman. We can see that it's negatively deviated from the population norm. And then this extent of deviation characterized by z-score is minus 1.97. However, here's come an 80-year-old woman, while the cortical thickness value is the same as the 50-year-old woman, but in her case, given her age, we'll consider as normal, so there's no deviation. So we did that approach for all the phenotypes, including the brain imaging, blood marker, etc., over hundreds of different phenotypes. Now we're trying to understand extent to which those phenotypes will deviate from, for people with disorder, just being deviated. However, it's very difficult to look at individual phenotype for the interpretation. So we come up with the idea of looking at organ system level. So basically, we summarize the phenotype extent deviation at organ system level. If the phenotype belongs to an organ system, we basically have a weighted sum of z-score, and that represents the extent to which an organ system is healthy or not. So I just show you a snapshot of the results, because the design of the model, so basically, if the person is not a healthy individual, we would expect a z-score over 0 across for all the organ system, while the more negative the organ health score is, the poor the organ health condition. So in this case, for each panel, is the mean score for each disorder group, and it's ordered anti-clockwise. So those rank at the top, that shows the most deviated organ health score, so they are the worst. So if we look at across different disorder groups, even though this neural basis within the brain disorders, but if you look at the extent deviation of their health score of the organ system, seems like it's a body system, overall body, and also the metabolic system, hepatic system, they rank at the very top. And only for dementia, where the brain gray matter is ranked roughly at one of the top. But if you look at other psychiatric conditions, the brain didn't show that much deviation compared to other organ systems. So overall, the conclusion is that we show this. What we think is that individual diagnosed with those neuropsychiatric conditions, they are not only just characterized by deviation from population norm for their brain health, but also show significant poor physical health across multiple other organ systems. This is particularly the case for bipolar disorder, depression, and anxiety. And interestingly, what we found, which is consistent across the 5 disorder conditions, poor organ health is most evident for metabolic system, hepatic, immune, and the renal system, while the metabolic system is often mentioned in the epidemiological study about diabetes, etc., but other organ systems were rarely mentioned. So this suggests that the importance of quantify those biomarkers, or like quantitatively measure those biomarkers, maybe can provide, even before the diagnosis, we can know how much the organ health might have been deteriorated. So again, this emphasized in practice, maybe we should focus on holistic mental and physical care rather than only treating the psychiatric symptoms, but we should also pay attention to their physical health, which has been really lacking in the, I think, current practice because of very specialized medicine system. So again, now I kind of show you some evidence. I know the importance, the association between physical health and the mental health. In the previous study, I look at them separately just to comparison, but I still want to know how they might interact. So one way to look at it is like, what's the role of the brain? So when I look into the literature, trying to find some explanation of the pathway that can potentially explain those interactions, here are some pathways that have been proposed in the literature, including but not limited to those. like, for example, the converging biological pathways like shared genetic disposition and immune dysregulation, and also pain-related alterations in monoamine levels, and the behavior, lifestyle, and factors, and also psychological factors, such as we know people with chronic illness, they have this, or cancer, they have the impending fear of death. So that psychological factors might also lead to they develop depressive symptoms. However, by looking at the literature, still not sure about how the brain play a role in this, at least at the population level, at macro scale. So in this study, so my hypothesis is that brain is actually a mediator. So potentially those physics, because we know brain body is interacting with each other. So their status of their physical health could influence their brain health and then leads to mood changes potentially. So in this study, to test this hypothesis, again, I used data from the UK Biobank. So I took a more transdiagnostic approach, not focusing on the diagnosis, but just look at the depressive symptoms and anxiety symptoms. And those organ health score is the same as the previous study. And we have the brain health score as well. And so I just show you, so we know the physical health, here there's a time difference between the brain and the physical health were assessed before the brain and also before the mental health. So we have this pre-temporal relationship that allow us to draw this directional inference.
Can I ask a quick question?
Sure.
So this is just like when you have that link C between physical and mental, that's just like a statistical model.
Statistics model, yes, exactly.
Otherwise, I wanted to see if there is another mechanism directly from physical to mental, which is not through the brain. But
yeah, there could be, yeah.
Since you're asking that question, I was actually, as you also tested for the model provide it goes from mental to physical.
That's a very good question, because that's something we really want to test. The issue with the data we have is the physical health always assessed before brain and then brain and before mental health. So this time sequence doesn't allow us to test the other direction. If we have data, if they have multiple time points, and then we can model both sides. Because I think it might be bidirectional, but we don't know which side is stronger, maybe, and depending on the age range as well. And so this is only thing we can do. So to test the hypothesis, basically, this is a mediation model or path analysis. So if the product of A multiply B, the coefficient is significant under the condition of total effect or direct effect of C prime, then we would say the brain mediates this relationship, right? So I first show this direct association. I use depression as an example. Anxiety is kind of similar, but for the interest time, I'm not showing that. So first of all, we show that there's a prospective association between baseline organ health and the mental health outcome at follow-up. So they always show negative association, basically means if you have poor physical health at baseline, a few years later, you might have more like a depressive symptoms. And so then we look at how the brain is mediating this relationship. And so those icon is modulated by the effect size. Basically, the organ icon is modulated by the direct effect to the mental health, to depressive symptoms, while the brain size is mediated by the effect size for the mediating effect. So basically, we show that there are multiple pathways through which the poor organ health might lead to poor brain health, which then leads to more severe depressive symptoms. And in general, we show that because we rank them from largest to smallest. So the brain had a relatively strong mediating effect on organs that have strong direct effects on mental health outcomes. This is particularly the case for musculoskeletal system and the immune systems. So the next natural question is, can we modify this mediating effect? Maybe we can have a better outcome. So the idea is to look at lifestyle and environmental factors, because we know there's kind of established evidence that lifestyle factors, like smoking, exercise, diet, has a strong risk factor for a lot of chronic physical illness. And also emerging evidence also suggests lifestyle factor impact on mental health. So the idea is to test whether the lifestyle factor can impact mental health via their influence on physical health and neurobiology. So this is the mediation model we constructed. So the idea is that if the path D, A, multiplied by B is significant under the condition of E prime, then we'll say this path is significant. So we included a very common, I feel like maybe 14 common lifestyle factors that people are very familiar with and also available from the UK Biobank. So this is a snapshot of the findings, very relatively busy but I just talk you through some summary of the main findings. So we show that some lifestyle factors, including physical activity, sedentary behavior like watching a lot of TV, and diet, sleep, and education and socio-economical status, they influence mental health while influencing multiple body and brain system. As you can see, there are some common lifestyle factors. So those lifestyle factors, if the color blue, they're generally good factors, good for your health. But if the color like black, they are like bad factors you should avoid. And they're also modulated by the effect size as well. But there are some other lifestyle factors, for example, smoking and alcohol use. If you look at panel C and F, where the smoking is, so what we show here is that smoking, this is not causal influence, but it's more directional from statistical point. The smoking could worsen metabolic and pulmonary health, which in turn leads to reductions in gray matter volume and subsequent depressive symptoms. Another interesting finding, which is not shown in the figure, is about psychological factors. We included a few psychological factors, and for example, this one is a lack of social connection. And we find that this is associated with higher score of depression. However, this association is not mediated by the past via the physical health and the brain, which may suggest direct impact from psychological factors on mental health. So as a quick summary here, we provide a very population level evaluation and a consolidated view of pathway explain the interplay between brain, body, lifestyle, and their collective influence on mental health. So we really hope that maybe in the future, taking on, we hope that the pathways we show here could inform further behavior interventions that can lead to a better outcome for physical and mental disorders.
Can I ask a question since this is a breaking point? So you are basically using graphical causal models, right?
Structure equation modeling.
Is it structure?
Yeah.
So then, and you probably mentioned this, but I forgot because I could see you had like different when you were presenting the results. They were like different hypotheses, right? The ones that you were, or did you try, for example, when you were talking about lifestyle, and then you have direct links to mental wellness, and then mediated through like physical health, right? It goes like to the heart or liver or whatever. Do you have like a parallel hypothesis where you just don't have the direct link, or just to like compare between the models to see which one, or is it even necessary? I don't know, maybe it's all.
Yeah, so this idea, it has to be there is a direct effect first, like this under the condition that direct effect like from lifestyle to mental health is significant. Then we test whether there's indirect path that can go to the mental health. So that's like a pre-assumption of the model in my analysis.
I see. So you first look for the direct. Makes sense.
Yeah, so I still want to have some more, like as I mentioned before, this population level characterization, and then have some understanding of mechanism. I'm not talking about molecule mechanism, but still at macro scale. So what is the mechanism that potentially can underline this development and progress of mental physical comorbidity? If you think about this as brain, right? The constantly receiving information from the environment or processing some information, but the brain is just not just working by itself and just okay, let's do something. They also send information to the rest of the body, and the rest of the body could also send information censored from the environment and send it back to the brain. So there is this interaction between brain and the body as a network. So this is what called brain-body axis is. So in this case, how are they connected or how they are interacting? So there are a few mechanisms that are being listed, many of them. But in my study over the past few years, have been primarily looking at these two potential explanation. One is aging, another one is immune metabolic dysfunction. So in terms of aging, so what is aging? Everyone knows, everyone age, right? So what is aging? And the first question I often ask, how old are you? And you might look at your ID. Everyone has ID here, I see. If you look at your date of birth, then you might be 40, you say. However, if I measure your blood, if I do a brain scan, the answer might be different. I might tell you you are 35, which is great, you're 5 years younger, but you might be 50, so you're 5 years older, which is not so good. So this is ideal biological age. Indeed, although everyone's chronological age is defined by how many years someone has been alive, but your internal organs might age at different rate. It's like the two clocks are running at different rate, such that the internal organs might have different age comparing to the number of years you have been alive. And similarly, across different individuals, the rate of aging might be different too. So this is ideal biological age. So if you look at the graph, like from James Cole in 2017, so the x-axis is chronological age, the y-axis is the risk of disease and cognitive decline, for example. So for the majority of individuals, like we say health aging trajectory, they might gradually developing they have the increased risk of developing disease and might reach a threshold at maybe age 80, they have some disease coming up. But for some other people, they might slightly deviate as following the blue curve, that having disease onset slightly earlier. But for some other individuals, they might reach the threshold of disease onset much, much earlier. So if we draw a vertical line for someone, everyone aged 60, you see that their risk of developing disease is different. So this is ideal biological age. This is the hypothetical underlying age of an organs defined by some aspect of their biology. So the idea is that the biological age may differ from your chronological age, and actually it might be a better indicator of disease, residual lifespan, and functional capacity, etc. So when I look at the idea and look into the literature over the past few decades, a lot of aging study has primarily focusing on molecular, cellular, like aging, like a mitochondrial dysfunction and genomic instability, or a lot of different things. However, we know that from a molecular perspective, this is great. It captures the potential molecule cellular pathways of aging. But when I'm thinking about disorders or age-related disease, normally the disease onset happen at organ level, right? So it's not like a cellular If we want to do intervention, if we just only have one cellular marker, where should we target? Will that help with certain like liver disease or kidney disease? So given from that aspect, I'm thinking about deriving some aging clock for different organ systems. So we have the biological age estimates to different organs, they might more related to their, or can maybe provide more information for the risk of developing certain condition. So how to estimate the biological age of organs? So I've used the brain as an example because I'm from neuroscience background. So this is the framework for brain age prediction. I'm not sure if you have heard of this, but the basic idea is that you have brain scans, either T1 or any other imaging modality. You can train a machine learning model and to predict someone's chronological age. So we can do either deep learning or regression or whatever models you want. And once you think the model is perform very good, can predict someone's chronological age, then we just take the model and we plug in someone's brain scan, the model will give us the predicted age. And if we look at the difference between the predicted age and their chronological age, this gives us an age gap index. So the idea is that if the gap is positive, which means your brain looks older than your chronological age. If the gap is negative, it looks younger than your chronological age. And if they matched, then great, it's just following the population norm. So we took the idea, we not only look at the brain, but also did the model for different organ systems using those phenotypes that we know that specifically or more have some specificity indexing the organ function. So here are some examples of main phenotypes included in the organ age estimation, but there are some other phenotypes in the paper. So the data we use from the UK Biobank, as shown here, it has a large number of samples. It has blood markers, physiological measurements, and also multimodal brain imaging, primarily MRI. So there's no PET, no MEG, or unfortunately, but it's very MRI heavy. So if you look at, so this is important, look at time of assessment. So they have baseline assessment for a large range of body markers and have repeated measure for subsample of the body marker. And they start to collect brain imaging and also have repeated imaging a few years later. And this is the gradually reduced sample size. And so this is the whole framework of the study. I'll quickly go through. Basically, we look at the medical history and the self-report. We kind of define two groups. One group is for model training. They don't have any chronic disorders. And we train the model. And then we use model to predict the organ age of an individual with any disorders. So in this case, and then we can have age gap estimate, age gap index for each individual and for each organ. Once we have that, we can do a lot of different things. We can look at aging profile in disorders what you are interested in, we can look at genetic environmental factors that might associate with, can explain the organ aging. And then we could also link that to mortality, say whether the aging could actually predict your premature death or survival rate, etc. So I say, so now we have the organ age gap, organ age for every individual and for every organ system. The first thing we're interested, just a very simple analysis to look at association. So to understand whether there is this external synchrony in aging among different organ systems. So basically, if we look at the body, there are two clusters. One cluster is renal, hepatic, and musculoskeletal system, while the other cluster is pulmonary, cardiovascular system, metabolic, and immune system. And for the brain, it's interesting that we show the strong synchrony between gray matter aging and white matter aging, while the synchrony is relatively weak, is much weaker with functional connectivity. The reason why I put them separately is because there's time difference, as I showed before. They're not assessed at the same time. So in this case, cross-sectional, and for those at the same time, I do look at the synchrony among organ aging clocks. More interestingly, because of the time difference, we could actually do something more. Because of time difference, we could say whether something at baseline could lead to some change at follow-up, whether there's this directional influence. So we call this multi-organ aging network. So the hypothesis is that an organ's biologic age would influence the aging of other organ systems. So to do that, I just put the time of assessment here, so to help you understand the results. So here, using structure equation modeling again, we look at whether body age at baseline would influence brain aging at follow-up. So
by influence, do you mean kind of a unidirectional causality or just a correlation?
So this is from structural equation modeling. We do some directional inference. So is this? Some people say it can be said causal inference, but I'm not sure. I don't think this is necessarily causal. But because of there is this time sequence between these two events, so we can test both cannot really test both direction because of the constraint of the time. So we can make directional inference from the structural equation modeling, but not necessarily causal, in my opinion. So in this case, we show that there are multiple organs that actually have influence on brain aging at follow-up. So among those organ system, the cardiovascular system shows relatively strong influence on brain aging. So whereby 1 year increase in cardiovascular age would lead to approximately 1 year increase in brain age at follow-up. Another thing we notice, this is, so before we only look at one time assessment age gap. Here, because there are two assessments, right? Like we can estimate the rate of change in organ aging. So we can know whether the aging faster or slower in comparison. So in this case, this network essentially means that advanced pulmonary age could lead to faster aging of cardiovascular system, and then leads to faster aging of renal system, metabolic system, and go back to have their influence on the musculoskeletal system. So if for people who are familiar with network neuroscience, so in this graph, the musculoskeletal system might be considered in-degree hub, which means it is very sensitive, or like it draw a lot of influence from other organ aging, which means it can be vulnerable organ system, like the aging of other organ system might all influence to the musculoskeletal system, like kind of makes sense in the end. Someone very old, like they cannot move, like they have some gait function issue, movement issue. So this is an insight from here. And again, if you look at different brain systems, the brain tissue type have gray matter, white matter, and functional connectivity. So we say this interesting is that gray matter aging might predate the aging of other systems. So the gray matter aging, advanced gray matter aging may lead to fast aging of the functional system of the brain. And then there is a bidirectional influence between functional connectivity and white matter aging.
Sorry, question while you got that. To what degree does kind of the natural variance in measurements impact the ability to show these correlations and maybe influence these results? And specifically, I think of like quantification of gray matter. That's something we can do very well. It's kind of a robust, high signal noise measure. Functional connectivity, maybe not so much. It's something, it's a measure, but it's a noisier measure. It certainly doesn't have as high as intrinsic signal noise. So when we talk about like directionality, gray matter influence and functional connectivity, how much do we believe that's the genuine directional influence versus we could just measure this much more precisely, so we're more sensitive to early changes. It takes a larger change before we're gonna feel confident that we've actually seen changes in functional connectivity, because the intrinsic variance is.
Yeah.
And so it's kind of, weighted by, some of these other influences aside from what may actually be happening biologically.
Yeah. Thanks for the question. I don't know if I can answer your question directly, like how much the variability or signal to noise ratio in functional connectivity can explain the results. But the good thing about this age prediction model is that we're not looking at individual functional connectivity measure. We're actually using hundreds of connectivity measures all together. We train this model to predict someone's age using their functional connectivity. So as together is actually, I mean, not from my study, some other study shows that it actually boosts the signal to noise ratio a lot. So it's significantly less noisy than looking at individual measures separately. So
I mean, one interesting thing to do is just in terms of the age effects, across 50,000 people or 5,000 number is, what's the variance along those curves? And how does it compare between the different measures? Might give you some sense of how much some of that, of course, is biological, but some of that may also be technical.
Yeah, exactly, because that's one of the caveats of this age prediction model. We still don't know how much is just because of noise or statistical residual, or is something reflect the actual biological residual. And by one way just to so for the using gray matter measure to predict age is more accurate than using functional connectivity for sure. So using gray matter, the accuracy is about 0.8, but using functional connectivity is about like 0.5, but like 0.5, 0.6. But the thing to know is that this difference in the prediction accuracy might be because of data noise, this statistical issue, but also could be just intrinsically the gray matter might age more aligned with the chronological year. The rate of aging of gray matter is more aligned with the year per year, like time is also just a measure. But the functional connectivity might have some, like it's not very much aligned with age, so might age at more different rate. That's why the functional connectivity might predict age not as accurate as gray matter. But this is something I guess still don't know. I hope maybe in the future there'll be some methods development can really disentangle this biological residual versus statistical residual. But at least if I can show you the next slide. So if I use, there might be this item our caveats in those age estimates, but when we look at those age estimates in disorders, so they actually make sense. So that gives us some confidence of those measures maybe still be useful. So in that case, we look at the age gaps in 16 different chronic conditions that we know, in aging population particularly. So if you look at these plots, so they are colored by the mean age gap per each organ, per each group, and that basically show the distribution. So one thing we noticed that so the organs we know primarily implicated in certain disorder, they generally age the most. For example, we look at the pulmonary system, they age most in people with COPD, among others. Like this show the red, so the red color means much older organ age. The renal system aged the most in chronic kidney disease. The hepatic system aged most in cirrhosis, while the metabolic system aged most in diabetes. And for the brain also, even we have much less data for the brain, but we still show that MS, dementia, those major brain disorders, they have much older brain age. And this is another representation just to have a comparison of how organ of brain and body they age in different conditions. So one show on the left is that so the arm of the clock points to the mean age gap in each disorder group. So here, just overall brain age, while we say that the brain generally ages most in people with major brain conditions, MS, dementia, even Parkinson's, but people with other physical conditions like diabetes, COPD, kidney disease, they also have much older brain age compared to their healthy peers. And similarly for the body age, even though major body disorder like kidney disease, cirrhosis, COPD, the overall body aged most. But people with mental disorders, they also have a much older body age. Yeah.
And if somebody has multiple conditions, are they like additive or synergistic?
So in this study, we didn't really quantify the extent of comorbidity, number of comorbidity. I just looking at them separately because they might be overlapping in the sample. But the idea is really to, if you have this condition, what's your brain age, what's your body age? It might be explained by comorbidity, it might be explained by other function, but I'm not trying to some pure condition, just that. I just say, if you have that condition, whether you age most than others.
Does your model allow for organs to get younger?
Sorry?
Does your model allow for organs?
It allows. So if the age gap, so this is where I didn't set like constraints, or it cannot be negative. So the age gap can be negative.
Okay, because I'm thinking because with certain intervention, some of the organs could actually get younger.
Could.
And that the fact that you are using data several years apart to make it
It's a disease from a certain lifestyle.
Yeah, exactly.
Yeah.
Vegetarians.
Yeah.
Yeah.
I
Eaters to the right.
Yeah, I think that'd be interesting to do some highly selected sample group, like very healthy lifestyle, whether their brain or body or look younger. I didn't do that. I just did association with a range of different lifestyle factors, whether that associate with the brain and the body age. They do. I didn't include in the slide, but we included a lot of lifestyle environmental factors.
Biobank has data on whose lifestyle.
Yes.
Super interesting.
Yeah, we could do even a binary group, not just to look at association. That might. So now currently only look at association. Yeah.
And since you assess the body age, the 2 time points, right? And they're a few years apart.
Yeah, 4 years apart.
On that data, if you have all the younger.
Yeah, I think
It's the same. I don't know if it's the same measurements both time points.
I think in healthy individual, we did look at whether the rate change. Like in healthy, it's usually flat. It's more at the group level, it's normally like flat. But in people with disorders, they show like a larger rate. So the rate is changing. So as a quick summary, this study, even though the scope of this study is much broader, not just the mental disorders, but for this talk or from justify my own thinking, from this work, I think that one thing to emphasize is that mental disorder are not just only associated advanced brain agent, not just the brain issue, but also associated with advanced agent in multiple body systems. Again, I really would like to advocate for physical, holistic mental physical care. And as an extension of this work, because I show this influence between cardiovascular agent and brain agent, a student in my group, so they took further, they used more sophisticated heart MRI data, the carotid ultrasound data, trying to estimate heart age in a more accurate way. And also using brain agent, not just by looking tissue type, I have gray, white functional connectivity. She actually used multimodal imaging to estimate the brain age at the network level. So she shows that the heart agent is more selected. It's not associated with all the brain networks, but more selectively associated with salience deformal network, somatomotor and subcortex. In the discussion, we think they might relate to the lot of regions like in the network might relate to the sympathetic and parasympathetic network, the autonomic nerve system. That's one of that's our main interpretation of this work.
And again, the structural equation modeling suggests there's a directional influence.
So in this case,
one to the other and not the other way around.
So
brain can obviously influence.
Yeah, so we don't have the data like can allow us to test the opposite direction. This is the UKB they kind of
very plausible hypotheses both ways.
Yeah, it'll be yes, exactly. So we really want to test which way is stronger and why some people may be this way, while some people are like different age range also. Yeah, yes.
Yeah.
Exactly. So what's the time? Okay, wow.
On time.
Okay, I'm just trying to talk about another hypothesis about, like I said, 2 hypotheses being testing. One is aging, one's immune metabolic dysregulation. So this very nice graph illustrate, I just use MDD as an example, illustrate several biologic systems that might involved in the pathophysiology of depression. So even though the underlying, like the sequence can explain those events, still unknown. We don't know anything and like don't know much about it. But one hypothesis can be that the stress response system, for example, immune system and HPA axis, the alterations in those stress response system, they might lead to alterations in the central nervous system and related mood changes, but just go up. But on the other hand, the alterations in the central nervous system might lead to disturbances of HPA axis and inflammation that might lead to like dyslipidemia and cardiovascular disorders. So in terms of the cardiovascular disorder and hypolipidemia, I want to just briefly, quickly go through what so the key role of lipids in this event. So in case people are not familiar with this, so lipids are carried by lipoprotein in the blood. Everyone knows about that. And according to the size and density of like different proportion of the molecule in the lipoprotein, there are actually different subclasses of lipoprotein. So those one, HDL, people know about it. So the HDL is like high density lipoprotein. So they are like considered good one because they carry unused cholesterol back in the blood back to the liver for disposal. So that's good. However, those very low density lipoprotein, very large one. So they are triglycerides rich and also can increase the plaque buildup in arteries that might block your artery and leads to coronary heart disease and a lot of conditions. So how are they related to depression? And in a recent study, they kind of meta-analysis look at the changes in the metabolites in depression compared to healthy individuals. So they show that MDD associate with downregulation of HDL, the good one, and also associate with upper regulation like elevated VLD and the triglycerides, as well as a wide range of plasma lipids, fatty acids, and low molecule weight metabolites. However, this study, they look at established MDD without and just they already been diagnosed with MDD in a chronic phase. So my question is, which comes first? Is that immune metabolic dysregulation or depression? So let's imagining a typical illness progression trajectory of MDD or any disorder. They might have some prodromal stage and they have diagnosis, then they have established with stage with multiple remission and relapse. So if the immune metabolic dysregulation happened at prodromal stage before the onset, this may suggest that the immune metabolic dysregulation might explain or may contribute to the risk of MDD development. So actually can be potential biomarker as screening to identify people at high risk. However, if immune metabolic dysregulation happened at a chronic phase, so may suggest that it's the depression related, either lifestyle change or behavior changes or medication, they might lead to the immune metabolic dysregulation. So to test that, we're still using the UK Biobank. That's the only one we have. So according to the medical records, so we define a group with established or existing depression that have been diagnosed with depression at the blood sample collection. And another group is prodromal depression, so which means they have not been diagnosed with depression at blood sample collection, but they develop depression later because we have the data linkage to the participants, so we can know when they were diagnosed with depression. And of course, a healthy group, across all the study period, they had no diagnosis with depression and anything else. So first, we replicate the previous study, and we showed depression associated with elevated systemic inflammation, as indicated by CRP, the C-reactive protein, and also another systemic inflammatory marker, the glycoprotein acetals. Yes. So that one in the middle, and also decreased HDL, increased VLDL, those very large lipoprotein, and also associated with reduced HDL and some other good lipids. However, so this is in the established depression. So we want to see how that look like in people with prodromal depression, haven't been diagnosed with depression. So those colored bar, they are the effect size or between group differences between MDD and healthy control in established depression. And those black line in the middle shows the effect size in prodromal depression. As you can see that even at the prodromal stage, they already have alterations in those metabolites, even though the effect size is attenuated compared to the established depression, but it's already show a very significant difference compared to healthy individuals. not only did we show the individual the changes in the individual metabolite, we're also interested to know the systemic change. So what do I mean systemic metabolic changes is that you can think about metabolism as like a chain of enzyme catalyzed reactions. So actually, conceptually, it can be represented as a network. So where we did a network style analysis, we look at pairs of coupling between metabolites and see whether the extent of coupling or pairing is altered in people with depression compared to healthy individuals. So the first thing you might notice, the two graphs very similar, which suggests similar systemic metabolic changes in the established versus prodromal depression. And here the blue line shows the reduced coupling between metabolites, where the red line shows increased coupling between metabolites. So the most, I think I want to highlight the most significant or most easiest spot finding is relates to glycolysis, like relates to glucose metabolism. So we show widespread decoupling between glucose and glucose related metabolites with other metabolites. So this actually suggests that potentially the glucose metabolism, the pathway can be a very good target if we want to try to do some intervention. That if we can normalize the glucose metabolism, maybe they have subsequent health benefits to other metabolites potentially though. So I think for the interest of time, I'll skip this. So this one, because we have two bloods collection, so we actually look at the change in those immunometabolic profile over time in depression. And it is relatively stable, but for the interest of time, I'm just not going into detail. So the final results I want to show is about the brain. So we want to know whether there's association between immunometabolic dysfunction and the brain structure, and whether that association is different in MDD versus healthy individual. So in this case, because we have like over 200 metabolites, the brain region will have like hundreds of brain regions, what to do. So the first thing we did, we ran the PC analysis of over 200 metabolites. We derived 3 PC components and look at association between the PC score and the brain structure. In this case is brain matter volume. And then the ways that if there's interaction that like that, so this shows deep difference in the association between depression and healthy individuals. So we only find significant interaction effect for this for the second PC component, which is represented by low albumin, and high CRP, and maybe others. So we know CRP is like a systemic inflammation marker. The high CRP is like inflammation, and albumin also shown in the literature, it has an anti-inflammatory property. So overall, this shows that the elevated systemic inflammation in the peripheral is associated with reduction in gray matter volume. So I show the most significant associations with the 2 regions. One is paracentral lobe and one is in the superior parietal lobe. And we see that's the trend of association we observed. And as a quick summary, so in this study, using this very large scale prospective cohort, we evaluated whether peripheral immunometabolic function is disturbed in depression and whether it changed over time and across illness stages. So overall, we find relatively persistent pattern of immunometabolic dysfunction before and after the onset of depression and along the course of illness. And very interesting, we show this systemic change in depression-related metabolomics implicating the core role of glycolysis. And we show some evidence the impact of peripheral immunometabolic dysfunction on brain structure. However, it'll be more interesting if we can look at neuroinflammation and to say whether there's association or link between peripheral inflammation and neuroinflammation. And again, so this study, the key message we want to talk to the public is it will be worth maybe to treat the chronic low-grade inflammation in those people, and might be beneficial for this outcome or overall quality of life for this people. Again, I'm just trying to emphasize this graph. So this brain-body interaction axis that can be represented as a network, I think will be a very interesting framework to study in the future in a lot of different conditions. And finally, I would like to thank the whole group and of course UK Biobank, a lot of imaging cohort, the funding agent from NHMRC, and also the group where Andrew Zalaski was my PhD supervisor, while I'm now having my own little group. So he's still my very supportive mentor in the group. We're still working very collaborative together, and also all the other people in the lab. And thank you very much for your attention. And yeah, I'm happy to hear your feedback and hear your thoughts. And if you have any common interest, we could do some collaboration on anything. And we're very grateful.
Thank you so much, Dr. Tian, for this wonderful talk.